the problem is, you will see the critical cases less often, obviously, than in the bigger centers.
Right.
But when one happens, you need to be as ready as, wherever you are.
So I think the best approach that we've pitched and that I've used in practice is kind of what happens if it gets worse, what happens if it stays the same, what happens if it get better, and keep cycling through that. Having that awareness and accountability that you're gonna maintain and manage your skill set to the best of your ability at a given time. Because there's going to be things that you come across that you just don't know.
Hello, everyone, and welcome to the Paratus Podcast, the emergency response podcast. I'm super happy to have Shawn Silvestri with us today. Shawn is a clinical support manager and paramedic educator with an advanced care paramedic background and over a decade supporting frontline and remote healthcare teams across Canada. He's built high-performing teams by improving onboarding, continuing education, and quality systems across air ambulance, industrial health, community paramedicine, and remote northern care. Shawn designs objective-based training frameworks, strengthens clinical governance and QA using just culture principles, and creates practical tools like SOPs, rubrics, orientation programs, and deployment readiness pathways. With graduate level study in adult education, Shawn brings a learning science approach focused on critical thinking, clinician confidence, and psychologically safe learning. So Shawn, thanks so much for taking the time.
Thanks so much for having me. It's great to be here. So when we get ready to deploy people into remote clinics, we give them a number of skills to work on differential diagnostics and things that will support them. With a paramedic background, we do come with certain skills that we train and hone on over time, and then adding in some of that. We talked about critical thinking in my intro and stuff, adding in some of those differentials that will support their work. So an interesting case that we had come across in one of our remote clinics was interdisciplinary, obviously, where there was a physician-led team, nurses at the table, and advanced care paramedics within the clinic. So an acute case that was going to be going out by medevac was identified. Initially, it was somebody who was in first term pregnancy and had a history of pelvic inflammatory disease. So the natural bias was towards this acute episodic issue with pain and discomfort and some concern around the pregnancy and supporting the viability of it. So the treatment path was chosen as empiric and supportive of the differential of pelvic inflammatory disease. One of the things as paramedics that we've been training on are things around the acute abdomen and how to diagnose it. And so with that kind of fervor and willingness to be thorough as the paramedic kind of took over care, within that team dynamic, there was a little bit of a reassessment that went on. So going through that assessment and going through the upskilling and the advanced assessments that we had done, they were able to isolate positive psoas test and obturator test, which supported a differential of appendicitis, which it ended up being. So we know that the empiric treatment would be very similar for both, but being able to point to specific care for that and consideration of the acuity and the triage of that medevac was better supported once those rule-ins, if you will, were present with the specific tests. So just an example of how working through the differentials and making steps towards ruling things in and ruling things out, I think really supported that patient outcome.
Yeah, that's really interesting. And a couple of things. First of all, the place you're describing, I'm guessing that's not a place with imaging, so everything had to be very clinical, so like history-based and physical exam.
That's right. So your presumptive reality might be your clinic where you have all the diagnostics available, or the emerge where you've got your diagnostic imaging just down the hall, right? Those things don't happen in remote clinics, unfortunately. So you're reliant on some point of care testing. Some of the the older primary care approach. So we do kind of hone those a little bit through our orientation and upskilling that we do.
And when you say that the patient was reassessed, I'm curious to have your thoughts on, obviously maybe even the physician came first and someone else is, coming after. Is that something that you teach or like, how do you feel about kind of that, going back into the diagnosis, making sure we didn't miss anything, reassessing, keeping an open mind kind of thing?
Fair. And it's just that, right? Like keeping the open mind and considering that, yeah, we don't have the diagnostic imaging that would be something more definitive in that case. So the consideration of, as you're getting that handover for the patient and you're responsible for pain control or symptom care, right? That kind of approach, but it just doesn't fit, right? So there's a colicky pain that's there and it's isolated to one side as opposed to the different types of pain that would be associated with pelvic inflammatory disease. So you're hearing that story and you're kind of scrutinizing it as you go. So with that scrutiny comes a little bit more curiosity, and then walking into those tests, right? Again, knowing that we probably don't have that definitive diagnosis at that point.
Yeah, absolutely. From that remote clinic standpoint, what does it change? Because you were saying, was the patient gonna be medevaced anyways, or like, so does it change how fast it's gonna happen, where the patient is gonna be evacuated to?
It could, right? Like, so just recognizing this, we're using this kind of as a catch-all example where something was picked up, right? So if you're triaging based on a less acute differential, and then it becomes something like an acute appendix, it might up the triage, right? So it considers kind of where somebody would be in line for that medevac.
How's your feeling, Sean, about the fact that you're remote, and obviously you don't have access to all these tests? How does that change, your willingness or the need, the felt need to, move forward in terms of diagnostics? Because I'm sure this person had probably been to the clinic many times. We've seen these patients who come again and again and again, but then exactly to the point you're bringing, the 100th time of a same clinical presentation doesn't mean they'll have the same, disease for the 100th time. So how does that change the fact that you're in a remote clinic compared to, for example, being in somewhere we said earlier where diagnostic imaging is down the hall? How does that change the way you approach this patient?
I think it has to be that sense that it is a new case, right? That you'll have their health records and things to go back on, different diagnoses or chronic disease management, et cetera, that you should pay attention to. But then recognizing that you don't want to get caught in that pattern recognition, right? It looks like this. It appears to be something similar to the past, so we'll treat it like we always did, and not doing that investigation. And further, I would think there might be more of a propensity in the more urban or built-up settings where you're going to rely on the diagnostics, right? So unless something shows up on the diagnostics, I can treat it that way. So you get a little bit more of a confirmation bias within that. So I think it's just reminding people to be aware, and treat each case as a new one, and go be thorough, especially in those settings.
Yeah, absolutely. As soon as you suspect appendicitis in the setting you're describing, the next step being imaging in any other setting, then I guess transfer would be the next logical step for that patient. Is that the only really possible option?
It really ends up being that way in a lot of the settings that we're involved in or deployed in, right? Where that next level of care becomes, or even those basic tests, right? Where imaging isn't available widely in these remote areas, so it becomes a flight to that. So you're more inclined, I think, to treat empirically, in a number of instances where you might not in a more built up center. So you're working towards, and you have that awareness, right? If it's an appendix, you could go into the rupture and sepsis realm fairly quickly. So just having those you kind of get ahead of it if you can, whenever you can. So you still, whenever you can, you're thinking about antimicrobial, antibacterial stewardship, and those principles. But there's a time and a place when you actually have to go forward with it.
Yeah, absolutely. Just to give us a bit more context, and there's this clinic where you were at, but the other sites that you work in, can you just give us a little bit of a feel of how big is it, how staffed is it, what the population you're serving is around there, and how far is it from somewhere else or from tertiary care, for example?
Fair, and I'm going to age myself a little bit. So your teams are made up, and I don't know if you'd remember this one, but the old Bits and Bytes commercial where you put your hand in and it's a different handful every time, right? So we go anywhere from having somebody in a mobile treatment center, MTC, which is the back of a pickup truck with a single medic in a pickup truck on a remote site, up to and including a clinic that might have nurse practitioner, physician, and various disciplines of nursing within there, including community health nurses, along with paramedics. So a large, fully staffed center might have upwards of 15 healthcare providers at any given time, and then down to the smaller, less connected ones that would have a couple of community health nurses and a paramedic in those ones. Our industrial clinics will have some physician assistants and occupational health nurses as well. So, and then that varies as far as the transport time. So it could be anywhere from a 15-minute flight to a couple of hours to the main centers in the north. So the the flight may involve kind of a stop at a regional center and then onto a hospital, depending on fuel restrictions and things like that. So there are considerations for the length of time, right? And so we do have the air ambulance within our structure, and we hand off to air ambulance in different areas where we're not providing that care.
Okay, and what defines if, because obviously the bigger centers have more the luxury of more staff. What defines if this professional is going to this place or the other place? Is it more a question of like the population that's there, the needs, with the past needs, or how exactly do you guys decide who's going to staff what site?
Those are ones where historically we've been the contractor in supporting the paramedic practice, and they would have structures that have kind of those clinic days or those community visits from different levels of care. So historically, you may get a physician coming in to do a clinic for pediatrics. You might get the community physician coming in, and they would go community to community for a period of time. And sometimes that's done by telemedicine almost entirely. So it varies. And it would be that would be us as the contracted provider of paramedics, and then the program being the existing kind of community support that's there.
Okay, and most of these places you can drive to, you have to fly to, or are both?
We have both that we've been involved with. In the more northernmost communities, it is fly in only.
When you can fly.
When you can fly, that's the other part. You do have long periods of time where you're waiting on your transport. So you have to maintain care until that medevac arrives.
So going back to your appendicitis case, if you're the provider taking care of this person, how does it change your approach if you're the sole provider with a clinic at the back of your pickup truck compared and, fly in only compared to, because I guess your triggers for, evaluation, transport is obviously dependent on your resources. So just out of experience, what's kind of your mindset around the different ways to treat these uncertain cases depending on where you are?
Yeah, it's kind of that all cause preparation. So, considering our team dynamic, you'd kind of you think about your code teams like with the ACLS approach or things like that, where you just kind of you get ready for the worst consideration and amp your team up, get prepared. If this happens, then we're going to do that. In those cases, right, where somebody might be just febrile with a sore belly, and that's your frontline kind of presentation is like, okay, if everything stays like this, we're good for several hours, right, until the plane comes. If it exacerbates or worsens in some way, then it becomes that, what are we managing here? Are we managing, hemodynamic stability? Are we managing an airway? Both. And then what's going to um, maintain that patient until like we can get them on to the next level. So I think you have to, if you put blinders on and you're not considering where it could go, then you'll be caught off guard a few times. So I think the best approach that we've pitched and that I've used in practice is kind of what happens if it gets worse, what happens if it stays the same, what happens if it get better, and keep cycling through that. And that to me is kind of one of the basis of clinical reasoning or critical reasoning.
And I'm just putting myself in the shoes of this provider. You can't either, call a helicopter or a plane for every person who has, a bit of a sore belly and some fever. But at the same time, you don't want to wait for 6 hours and then not being able to fly because there's a snowstorm coming in. So have you found a way to kind of gauge this equilibrium, or is it always a challenge?
I'll say that I'll put it out first and foremost that this is a team decision, right? So it's physician led in those cases, right? So you're consulting with the physician, typically remotely, and making that decision. You're the eyes, ears, hands, working through the assessments, giving differentials and having that collaboration in that sense. And then that decision is a shared one, oftentimes ultimately with the responsibility lying with the physician, right? So they're aware of kind of the resources of the medevac and where the destination would be. So I think you have that collaboration, and again, it's interdisciplinary and it's collaborative, and you work together to make sure that you've kind of checked all the boxes to make sure it's the appropriate decision at the appropriate time.
How big are their communities where these are based? Is it like hundreds of people, thousands, bigger for the bigger centers?
Anywhere from a couple of hundred to a couple of thousand.
And how will you be out there? Like, do people stay like long periods of time with the same stable teams? Is there a lot of like turnover of personnel? How does that part work?
I think by and large, you do, like from our perspective, there's some stability. You can get into a regular shift pattern if that's the place where the person wants to be, and then somewhere that they need our services, and then it would be the different models of how they would employ the community health nurse skill set, right? So some are in-house, some are contracted. Um, where we're the sole proprietor, like in the industrial, we're able to get people with regularity, and that does, they get familiar with the clientele and with the workload, and I think that's the best case scenario. At times it is fairly ad hoc, so you're kind of learning a new area at a given time, but the same principles kind of apply within that.
Yeah, because I could really see moving from makeshift clinic at the back of a pickup truck compared to the bigger place and then the industrial side. The decision making is very different from
Yes.
place to place. So where you're stationed to the same place and going there regularly, you start to know what type of things people present with, but you also start to understand your system of who's the second call, how do I get someone to higher level care. So it must
That's
be
right.
easier at some point if people are positioned somewhere for longer.
That's right. And if you can imagine, we do different types of onboarding for the different scenarios that we're talking about, right? So we try and tailor it to the specific environment that they're going, with the most amount of preparation that we can.
How does that, talking about onboarding, how does that change? Is it very different? Are they all getting kind of the same basic stuff and then you add other things, or is everybody being kind of taught but onboarded the same way, irrespective of what size of site they're going to?
If I had my druthers, it would be the same for everywhere, because I know how good or how comprehensive our full kind of clinic approach is. It goes back to kind of what's being funded for the training and how long we have the people for. So some of our industrial sites, the contract requires, ACLS and BLS as the minimums, and then certain specific point of care testing that would be required on that specific site. So onboarding can look, that way. We take a paramedic come as they are and support them with the site-specific pieces for onboarding, up to, a comprehensive kind of 9-day onboarding that includes almost 6 days in class. That's just a bit more robust, and it recognizes the programs that are going on in the communities that they're serving, as well as the various clinical presentations.
Okay, wow, that's really interesting. So, can you take someone fresh out of school and put them through that onboarding and then release them to these sites? Is there some background experience required?
Yeah, so we defer to what our best judgment is, and then sometimes what our client, the contract is. So we want them to have a couple of years of emergency experience, typically, for the jobs that are a little bit higher stakes. So there are some that are more suitable for somebody with less experience, and then the ones that were really going in, for that prolonged kind of deployment, and with a little bit more extensive of um, onboarding pieces or supportive pieces within the communities. Then we want to have people that have had that experience on the job prior. It kind of it hones them in to recognize, you go back to the basics of sick and not sick, but also you work through some of the differentials and the critical thinking through that period of time. And you've got the support of being typically close to your emergency centers, right? So we rely on a fair bit of that experience to support them coming into this environment.
So, your person is coming in, and you, Shawn, are responsible for the onboarding and teaching part. Is that right?
So now I employ the person who does that. So for a longer period of time, I was the one that was onboarding a lot of the staff for that. So we do have our air ambulance educators that look after that side of the house, and the community and industrial side has an educator dedicated to it. So that was me for quite a period of time, a couple of years. I think we talked about, as I was counting it up for this, it was around 150 people went through that were onboarded for the community industrial programs. So
Wow, that's amazing. Can you tell me a little bit what that entails exactly? You said it's a few days, because then you're taking people that have, training and then that have some work experience. What are you putting in there that's extra stuff that you think is like the most important thing they have to learn? And I'll be interested after that to jump into how are you teaching them that?
yeah, fair enough. So we landed on a number of clinical reviews and supportive pieces for paramedics. So when you get people together from across the country, there's different approaches to how they deliver care. So there's some places that have protocols, medical control protocols, some places that have clinical practice guidelines, and they're usually informed by things like heart and stroke or AHA approaches to care. So we kind of work on standardizing that. So we do run through heart and stroke, BLS, ACLS, PALS, and myself and the other educators are all instructors in that. So we do that as kind of the common language. When we go into facilities, typically they're using those as guidelines with their local. They may have a cardiologist that influences energies on defibrillation or cardioversion. That's fine. Those are local protocols. But if we get them into that, the language of the land that you're going into, so to speak, then it just kind of gives us an opportunity to standardize what we're bringing people out as for the emergent care. We go through obstetrics review and NRP review as well, and some common primary care for pediatrics, and then get into some advanced physical assessments. So there's some pretty great guidelines that they use in some of these areas, and we're able to uh, do some of the special tests, like show them some of the special assessments and tests for each body system that support working in the clinical practice guidelines and building up their differentials. So we work through that as our advanced physical assessment module, and then go through some case studies. So applying it while they're in the classroom, letting them have those first attempts and working through the clinical practice guidelines and applying it and doing some case studies with some consultation brings it all together. So just using the communication tools that they're going to use, like SBAR, and then SOAP note charting as a whole other thing that paramedics don't typically do. So we go over those things as an upskill and support. And then, finally working through some of the point of care testing, different tools that we might not use, right? So fundoscopy, otoscopy, things that you wouldn't necessarily do on the road, and supporting that. And then some basic suturing and plaster Paris splinting as well. So things like, simple lacerations can remain in those remote settings and not have to be medevaced, right? And that's within the scope of paramedics. So yeah, there's a lot of that. And then there's kind of formulating treatment plans and assisting in dispensing medications for acute episodic care. Those things are all kind of additional pieces that we go over to support them before their deployment.
Okay, wow. Big, a lot of very important and heavy subjects.
Yeah, exactly. But it builds some rapport, right? So it builds rapport with us, and it builds rapport with their team. So these are people they're going through the training with, maybe having those aha moments together. So it kind of builds some confidence within that controlled environment with them.
So you have all this stuff to cover. You don't have, months. It's
Yeah.
more like in days. Plus, you have people that have experience working, so they're basically usually adult learners. And I know this is an interest of yours. I'm really curious to hear your thoughts on how do you teach differently to these people than you would teach to someone who's, in school, 20 years old. Mm, the fact they've seen stuff already, but they already, like with what you've just mentioned, they still have a lot of things to learn and that are very important and very content heavy. So, what's your approach with that teaching?
Yeah, it's kind of taking some time to recognize where the individual is and being supportive, right? So I tend to lead with empathy, curiosity, and try and do it in a supportive manner. So if I can have a moment with kind of education theory and where that goes with us, it's recognizing that there's validity to them right when they show up. So they're coming in with their experience. At a base level, they're certified paramedics, and they've had certain experience coming to the table. I know from my own experience entering the program that there were things that I was unsure of, right? So I can have that direct line with empathy, right? So as they're going through, I know that paramedics have taught themselves different things over the years to get themselves ready for different environments. So a lot of the time it's kind of presenting the information to them and letting them have a moment to kind of take it all in, and then bringing it out to play with. So I've gone over a couple of little education theories within that. So pedagogy is the practice of, teaching yourself and supporting yourself in given environments. And adults do that. If you were, through your schooling, if you had recipe cards and you're memorizing pieces of parts of anatomy and things like that, that's your process. People will have their ways that they got good at something, right? They practiced it over and over again. Like think about an airway skill or something. They went to the lab as extra time and they honed that in. So some of the times it's just about like giving the information and then getting out of the way. Right? It's not that you need to hear me and impart knowledge upon you. It's like I need to present what our goal is, work through it, and then give you some space. So that's kind of what I work towards. And then just guiding any of that practice that look like things that we want to hone in, and or asking them how they feel about it as it's going through. So you can support them in a number of different ways, right? You may watch them do a perfect intubation and doing bag valve mask on somebody perfectly in your view, and I've got the metrics in the back because we got some cool mannequins. And they're kind of hard on themselves, right? I can never do this right? So then it's supporting them and giving that feeling what success is. So those are kind of those things that mix in. The other one's social constructivism, right? Where they're going to start to listen to what you have to say to build on, what they need. And then they need somebody who can scrutinize it with them. So once, learning is a social construct. So it's like, I think it's this way, I present it the way I think it is, and then we give a little bit of feedback, right? And that supports them moving forward and can really be a confidence booster, right? So if I was to kind of like say, no, that's not the way and take it over and show them how to do it again, that's me again, putting myself into the mix of it and trying to impart the knowledge as opposed to, working through the curiosity, honing that one piece. And it's those little like micro adjustments and supportive messages I find are much more effective than trying to direct it specifically and control it. So I think that builds the confidence. I think in a short period of time, if you can go through a number of things like where you can build rapport and trust, and you can work through things with curiosity and allow for that questioning, then I think that creates that safe environment and can build confidence in a short period of time.
So many things to unpack in there. You mentioned curiosity many times. Do you encourage them to be curious? Do you leave space for curiosity? How does that exactly happen? Because you kind of have to create that or make them understand that the course is built for them to be curious. How do you accomplish that?
Yeah, it's really just recognizing that those questions are important. So I've caught myself a number of times where you're obviously you're on a schedule and you're trying to work through a volume of information, but then just recognizing and encouraging them to ask questions when they're not sure. Some people learn best by paraphrasing something and giving it back to you. So giving space for that kind of activity and then taking the time to follow it through, right? Because that may, the person that was sitting in the corner quietly, maybe they weren't comfortable putting it out there until somebody else did, and then you're working through that, and then they get the confidence to step up. So if we're kind of moving past that and not allowing space for curiosity, is everybody really picking it up?
You also mentioned giving them space after you show them something. You've mentioned so many things they have to learn. I'm sure the schedule is jam packed. How do you like? Is there? Did you find a way to give space, but you can't give them 2 hours? I mean, it's not the time to just go like they go for a walk and then they just kind of think about these things. So how does that translate? And when you say give them space, do you give them like specific tools, or is it more that you're there to help them during they have some bit of time to explore?
Yeah, definitely. There's time for them to practice what we're working on. And those are built into, I try and build that into any activity that I'm doing and encourage, our team to work through it that way. Yeah. So there is time, always allotting time within the learning module to have the question and answer and have the ad hoc conversations that are necessary for knowledge transfer, but then offering that the stuff doesn't get put away right away either, right? So those times where I'm the facilitator or my crew is helping to facilitate the educators, where that lunchtime period might be your time to have a bit of time away from everybody, right? They want to practice another skill for a period of time, end of day, things like that, where it's, I just need a little bit more time to work on that or to have this question answered. So I think, you do have that time, that structured time within the day, with space, but then giving them the opportunity to let things percolate a little bit and come up with those questions. It may take a bit of time to formulate their comfort level in asking the question or within the skill itself. So we do allow for space and make those offerings, as we're working through this stuff.
So what would you say the ratio? I remember when I was in school, I think it was 100% lectures. That was a pretty easy ratio to
Yeah.
to remember. What do you feel is the ratio in these courses? Is it like 50-50 in terms of more theory and then practice, or does it depend on the topic?
I think it depends on the topic. I think there's inherent knowledge that you expect with the people that we have coming in. So we do like we problematize things and stress that a little bit to see where somebody might have challenges or support that. But recognizing that we do have licensed paramedics coming in as the baseline. So there is that understanding with the information that we provide, I mentioned that the advanced assessments, we do a primer online. So the thing I didn't mention was the e-learning that we provide ahead of time. So there's an opportunity to review body systems and get a sense of different body systems, ranges of motion, normal body function as a review before they come in. And then we do support it with a guidebook that works through a number of those special tests as well. So we do have the various types of media, and then we do have some didactic to go along with the lecture. And really the lecture is kind of working through demonstrations in the lab and with partners, with an exam table or with a mannequin, so that we can work through these things and bring them to life. Because you and I probably both know, sitting in the lecture hall looking at slide after slide can really it's really difficult to attain knowledge transfer in those circumstances, I think.
Yeah, and I think the older you get, the harder it gets. So, 100%.
Agreed.
So you prepare them before, they have some stuff to prepare for. You have the courses which are as hands-on as possible. Do you already prepare? Because you were talking about giving them space, because obviously the days after, I know when I go to practical courses or obviously you think a lot about what you've learned, but you might not see a case in weeks, months, years. How do you think about that part of making sure that, for one, you consolidate the knowledge you've
Mhm.
acquired during the course, being able to go back to that stuff and review the days or weeks after, but also making sure you're able to retrieve it when
Yeah.
it's required later in time?
Yeah, for me, I go back to kind of my early days when I was preceptoring students on the ambulance. It would be like, pick a case and walk through all of the things that you would touch for that case, because it gives you the muscle memory. It works through those differentials, the questions that you want to ask, the special tests that you want to do, or the diagnostics that you want to do within that. So I think there's something to be said about keeping your mind active in that way. If you're not getting the actual casework, if you get, you know, ear infection after ear infection, and then suddenly there's a acute case, what's keeping you ready for that, right? So working through that, once a week, once a rotation, something like that, where you do that. So we would also encourage like mock codes to support that if you are in a slower area. So we encourage and support that whatever way we can. And then, working, often talk about a community of practice, right? So if you have somebody who's more knowledgeable on a certain area than you, uh, work with some fabulous NPs, and we know that their primary care skills are honed right in. So there's things that you just be kind of sitting back and running through a couple of cases with them and bringing it to mind, right? So informal kind of case review rounds really helps as well, in those ones that you might not have seen quite yet, or get them to tap you on the shoulder when they get that one too. So be open to those opportunities. So there's a number of different ways that I've kind of worked on keeping the rust off, and then supported other people to look for those opportunities.
And especially in the rural places, the problem is, you will see the critical cases less often, obviously, than in the bigger centers.
Right.
But when one happens, you need to be as ready as, wherever you are. And obviously, seeing these cases often, you work on your framework and, their perception and your diagnostics and all that stuff. But when you don't see it very often, to your point, you need to make these practices happen. Or else if you see a case every 5 years, then you probably won't be ready to take care of that patient.
Yeah, fair.
We talked about curiosity and confidence. You also mentioned resilience. Is that something that you teach during the course? Is there a way you find to set up resilience during teaching?
It's to me, I kind of have a correlation between confidence and resilience. And one of the best quotes on resilience that I've heard recently, is that resilience is great, but it really sucks when you're there, when you're working on your resilience, right? So when you're in that mode, it's difficult. So those opportunities that we have to um, structure some confidence to get through those tougher times. The classroom's one of them, right? And when we're doing training, that's a place where we can support it. But we also have opportunities at clinical debriefs, and some, you know, discussions on the fly, right? So we do continually offer that reach out if people need it, and running through, much like you might have a clinical debrief around an adverse event or things like that. We'll work on that, but we certainly offer when things people want that support on an ongoing basis when they're on the job. Uh, Going back to the onboarding, it's really is back to giving space to recognizing the different cues from the people that you're working with, that might show they don't feel super confident, right? So you see somebody who's been the quiet participant in the back of the room, and you just give them a gentle nudge, or let them know that it's their case to work through. And hopefully you've shown them enough times through the other debriefs that it is okay to, you know, work through problems, or have a moment where the skill doesn't feel quite right. I think those moments and getting the support at those times is one of the pivotal things that gives people resilience. The other one would be kind of giving them those critical reasoning or reflection skills. So oftentimes when we're working through a debrief, even in the cases, you think about the heart and stroke cases that we're doing, we go through numbers of cases, the case studies, um, ask them what felt good, what didn't feel so good, and just wait for it. Right. Rather than me listing off the 5 or 6 things, your IV didn't go in at this time, you didn't defibrillate within 30 seconds. Those are fairly base level, right? It's like you didn't pass the check sheet, as opposed to, what did you see? How was your team functioning at that time? What more did you or they need? And ask those questions. And really, you're trying to build that up to a point where they're doing that cycle as they work through problems. So when we see people that are in that overwhelm, or not looking like they're particularly have a lot of resolve at the time, they might not be reflective at that time, right? So it's like, what was I trying to accomplish, or what were the expectations or the guidelines around this? I'm able to meet that. And, I've done all I can, and I go forward, and the case ends the way it is, but I followed everything that I was supposed to, right? Or this one didn't feel great, so I reached out to this person, and I was able to support myself in that time of, when I was feeling a little bit shaky. So I think resilience comes from, knowing that they can have that curiosity or having that support at given times, or support themselves.
Yeah, absolutely. Really interesting. You mentioned preparedness there, and obviously that's a topic that I really like. Who do you feel, or what do you feel is the most important? Is it a combination of all these things to be better prepared? Do you find there's a common trait to people who respond the best to these, unexpected situations? What are your thoughts on that?
Yeah, I think having that awareness and accountability that you're gonna maintain and manage your skill set to the best of your ability at a given time, right? So you're working on keeping up with the research, maintaining your certification to your skills, aptitude, and those items are accountabilities, right? That you'd be wanting to make sure you're on top of. But also kind of knowing where the resource might be that would support you if it's something that you don't know. Because there's going to be things that you come across that you just don't know. I think back to the physicians when the Palm Pilot came out, and here's me as a young medic, and I'm like, okay, so if these people have gone through school for 8, 10, 12 years, and they're still going back to an additional resource, okay, it's okay for me to have my protocol book out, or it's okay for me to look at my heart and stroke algorithm, right? And that's kind of how we've evolved and supported people. It's like, if you don't know, just make sure that you're recognizing that, and you're continuing to look for the resource for that. So I think that supports people. So if they're aware of that, if they don't know what they don't know, or if they know that they don't know and they're trying to push through it, that can be problematic.
100%. I so agree. And knowing where to get that information ahead of time, right? If you know what you don't know, to your point, and you know where to get the information and how to get it fast, or who to call, then obviously you'll get yourself out of trouble most of the time, because it's impossible to know everything.
Yeah, exactly.
Absolutely. Do you teach during your courses? Because when something happens that the person needs to be evacuated, um, you need to get on the phone and talk to usually more than one person,
Yeah.
sometimes one, but oftentimes many people. Do you teach in your courses specifically? Because I'm sure that's not a skill set everybody has, and especially in certain situations in urban settings, you never have to do that. But do you
Yeah.
teach how do I communicate? How do I present a case? How do I convince the person that when I look at the patient, I mean, there's no doubt this patient needs to be transferred, but sometimes it's hard to communicate that.
So we do have the tool that's predominant is the SBAR tool that that people would be trained on, so that you do have a universal communication approach, Eh, but also recognizing that your discussion might be scrutinized and having that information available, and it should be scrutinized. Really, like if we're thinking about the environment that we're in, they're doing again. I go back to reflection, right? Does my plan hold water? Do I have all the makings of what should be a medevac in this case, right? So, it's something that is, life or limb threatening. They do need to be managed at a different care center. There's not the specialty that we need for diagnostics or treatment. It works through that approach, and then it's conveying that to the decision maker on that. And again, I do find that by and large, it's very collaborative and supportive. So if they don't have the answer for the person on the other end of the phone, it'd be like, I just need you to do this, right? It might be a point of care test or a different assessment along with it. But there's some people that do talk about being, they feel like they've been grilled by the end of it. And I think both are approaches to care, that person's comfort level to make that decision. So I think we need to be ready for both. And by having, the most comprehensive assessment ready ahead of time and some notes, and a communication tool that supports it most often. Um, but again, recognizing, people will have their own criteria at times when you're working with them to support that. So just being ready to, you know, work through that with them at any given time.
Finishing on the topic, Sean, when these people are go to their sites and they're alone for a while, is there some regular training? You say that you obviously encourage, to go through cases and to do some mock codes and that kind of thing. Do you ever bring them back and do some formal, like up to date training kind of thing?
We work on we work on providing continuing medical education to folks as well when they're deployed, and various environments do have that in support of the uh, interdisciplinary practitioners. So they'll engage with it at the site, but then we do try and offer up to like some CME. We've done different rounds specific to certain case studies, and then we've done some grand rounds. So we title it grand rounds within our company, and it's kind of all four service lines can come together with a subject matter expert and go over those things. So we've done a few different approaches to that.
That's really interesting. Which one do you find resonates more with people? Is it the rounds? Is it the mock codes? Is it what usually gets the probably better reception, but at the same time, which one do you feel brings in the most, like the people remember most?
Yeah, I think as a tool, the what you can do, like drilling and skilling, the support each other on the ground, there's so much benefit to that. The team building aspect, being able to scrutinize your performance and stuff. I think there's a lot to that for the teams. The one that probably got the highest we did one, sorry, that was kind of a palliative care reminder, and it was bringing in some of the expertise that our paramedic group had done on their ground care as community paramedics and stuff. So they had done some previous training, and they were able to support their colleagues with, again, it wasn't extensive in the clinical treatment side, but just some recognition of the patient palliating and things that we could do to support them. So that ended up being a rounds within one of our service lines, and we were able to get the Dr. Alex Poole in for a grand rounds on frostbite because he's done some innovative work in the Yukon on frostbite care. So that was very well received. We were able to bring some external partners in with that as well.
All right, that's amazing. Love it. Um, Sean, open to a couple of quick fire questions before we finish?
Absolutely.
All right, let's go. Um, have you changed your mind on something in the past year or two?
Yeah, I have changed my mind on an approach that I'd used. I'd done a lot of things kind of recognizing that, people are looking for a certain thing from me. So I've branched out and gone alone a couple of times, and being brave enough to, stand behind the things that have made me what I am. Like educational theory, uh, in support of some of our staffing development and policies. So I really feel it's important. It brings forward kind of the principles that I believed in for a long time, and have really supported my growth and others. So standing alone is one of those things that I've done a little bit more of, and thankfully I've got a supportive team, and it's been a successful endeavor. So
Very cool. Congratulations. What are you never asked either about your job or educating adults, as we talked about today? Something that you find that you should be asked more often, or that people aren't asking the right questions, maybe?
fair enough. I think the how, it's sometimes the why, but then like, how do I know I made a right decision on something? And asking the why and the how are important. The reasons why, I think I got into it a little bit on the last question, but being principled and stand behind things is important, and I've seen positive results from that. Why would I support critical thinking, critical reasoning? Why would I support confidence building? Why would I support just culture? Because I've seen people turn things around profoundly by using those. So yeah, to me, it's recognizing, that you get asked what you do all the time. You get asked what cool places you've been. What does your team do? What can you do for me? But kind of like the why and the how of your decision making. I think that's one that um, you could really learn something about somebody and maybe about a process that you're working on by doing that. So
Absolutely. And last question for you, Shawn. What are you optimistic about either your current job or your profession in general for the future?
I see some really great people doing some very cool endeavors with my profession. So I think I'll coattail a little bit on what some of those academics are working on for the landscape for paramedicine in Canada. I'm excited about research that's being done by paramedics for paramedicine. Uh, and that will support the larger medical community. So as I see people getting legs underneath them as academics, and some of these people I know personally have kind of started from the ground up, and are now PhDs and creating some really cool studies for paramedicine and for the medical community. I think that we're going to grow by leaps and bounds by having this stuff in there. You know, Dual sequential defib was started in Toronto with some of the paramedics in the services around Toronto, and now look at it, it's world renowned. The studies on, survivability above the third floor was an initial study by a paramedic in Ontario, and it's gone worldwide. So just seeing those things get legs and starting to support the profession, and again, the greater medical community, I think it's very exciting, and I think there's so much more we can grow with paramedicine. So I'm excited to be a part of that and watch it grow.
Absolutely. That's very exciting. Shawn, thanks so much for taking the time. I really appreciate our conversation.
Thank you. I really appreciate being here.